So let me start with microcytic anemia, a very common anemia. A 34-year-old woman, occasionally fatigued but otherwise healthy, uses no meds, normal physical exam. CBC shows hemoglobin 10 grams, the normal is 14 for a female, so this is low hemoglobin. Hematocrit 32, the normal is 45, this is low hematocrit. MCV 73, this is small red blood cell. What is the most likely diagnosis? Now, the presentation of any anemia, no matter what is the cause, you will get pallor, fatigue, shortness of breath. Pallor, fatigue, shortness of breath. These are the manifestations of anemia regardless of the etiology. So, how are we going to differentiate? You have to look at the MCV. Here we have microcytic anemia. So what is the most likely diagnosis? It could be iron deficiency anemia, yes, and this is the most common cause of microcytic anemia. It could be anemia of chronic disease, it could be sideroblastic anemia, or it could be thalassemia. It could be any of the above. It could be any of the above. But the most likely is iron deficiency anemia, because this is the most common anemia ever. So let's differentiate between the four conditions. And let me start with how to diagnose or to differentiate between them. Let me start with the iron studies. It's iron deficiency anemia is the most common one. But in thalassemia, the problem in thalassemia is not about iron at all. So thalassemia is the only microcytic anemia where you have normal iron profile. The problem is in the globin portion of the hemoglobin, whether the globin alpha chains, as in alpha thalassemia, or the globin beta chains. So you get normal iron studies and you have to do electrophoresis to diagnose thalassemia. Sideroblastic anemia, usually caused by alcohol intoxication, lead poisoning, sometimes by vitamin B6 deficiency, isoniazide toxicity. Sideroblastic anemia, a very rare cause of microcytic anemia, and this is the only anemia ever where you get elevated serum iron, and you confirm the diagnosis by Persian blue bone marrow stain, and you will identify too much iron. The only anemia with elevated serum iron is sideroblastic anemia, which is very rare. So we are left with iron deficiency anemia and anemia of chronic disease. Any chronic disease, rheumatoid arthritis, tuberculosis, systemic lupus, chronic kidney disease, malignancy, you will get anemia for unknown reason. For unknown reason, we get anemia with these chronic diseases. Iron deficiency anemia, and the most common cause, and that you will find in the history, some cause for a chronic blood loss, either through the GI, maybe the patient is using too much NSAIDs and he is developing kind of superficial gastric erosions, and every day he loses tiny amounts of blood. This is sufficient to cause iron deficiency anemia, or maybe it's excessive bleeding that is menstrual related in females, and again this will lead to chronic blood loss and iron deficiency anemia. It's very hard to get iron deficiency anemia on dietary basis. Low intake is it is possible, of course, but not as common as the chronic blood loss. So how to differentiate between the two? Is it iron deficiency or is it anemia of chronic disease? 3 iron studies we have to do: serum iron, ferritin level, and total iron binding capacity. Serum iron, ferritin level, and total iron binding capacity. The serum iron is low in both of them, iron deficiency and anemia of chronic disease. But we have to look at the ferritin. The ferritin is low in iron deficiency, whereas it is high or high normal in anemia of chronic disease. What is the TIBC? It's the total iron binding capacity. It moves the opposite way of ferritin. Why? Because when ferritin is low, there will be more empty binding sites waiting for iron. But the problem is ferritin is low, so the TIBC will be up. The opposite happens when the ferritin is high. High ferritin means what? It's occupying all the binding sites. So the total iron binding capacity will be low, and this is how we differentiate between iron deficiency and anemia of chronic disease. In addition to that, which one has high platelet count? Iron deficiency anemia. Which one has high RDW? Iron deficiency anemia. Which changes first with iron replacement? When you start treating iron deficiency with iron, reticulocytes increases first. A patient with iron deficiency does not improve with oral ferrous sulfate. What to do first? Yes, encourage the patient to take vitamin C. Have orange juice with your iron, because it seems, what's vitamin C? It is ascorbic acid. Ascorbic acid, orange juice, something acidic. It seems that iron loves a little bit of acidity in the stomach in order to get absorbed. Which of these decreases iron absorption? Well, if acidity increases iron absorption, so definitely something like proton pump inhibitors, which decrease the acidity in the stomach, will decrease iron absorption. Which of the following readings represent anemia of chronic disease? So now let's have a quick look. Which one of these four conditions have elevated serum iron? Yes, it's case B. So case B should be what? Sideroblastic anemia. Case B should be sideroblastic anemia, the only one with elevated iron. Now, which one has low ferritin? Low ferritin. A has low ferritin, iron deficiency. Look at case C. In case C, we have normal ferritin, but the total iron binding capacity is elevated and the serum iron is low. In 30% of cases of iron deficiency anemia, you can get normal ferritin, normal or low normal serum ferritin. Why? Because serum ferritin is one of the acute phase reactants in any inflammation, in any inflammatory condition. Your liver is going to make more ferritin in any inflammation. And inflammation is very common. Common cold, you get inflammation of upper respiratory tract. Minor trauma, you get some minor inflammation due to tissue damage. So inflammation is common. So having anemia of iron deficiency anemia with a normal ferritin, it happens 1/3 of the time. So the anemia of chronic disease will be case D. What do we have? We have low serum iron, we have normal or high normal ferritin, and we have almost low, very low or low normal total iron binding capacity. Anemia of chronic disease is case D. 63-year-old woman with anemia. She drinks socially 3 nights a week, no symptoms, MCV 70, white blood cell count normal, platelet count 636, 600,000, almost 600,000. What is the most likely cause of this thrombocytosis? Well, if you're thinking essential thrombocytosis, to have this diagnosis, you have to have a platelet count higher than 1 million. So it is iron deficiency anemia, the only anemia that increases the platelet count. Our case study for iron deficiency anemia is about 37-year-old woman who presents to her gynecologist complaining of a 2-month history of intermenstrual bleeding, menorrhagia, increased urinary frequency, mild incontinence, extreme fatigue, and weakness. What are the contributing factors for the development of iron deficiency anemia in this patient? Probably chronic loss of blood due to the menstrual irregularities. What is the potential significance that the patient was born of Greek parents? Beta thalassemia is a type of anemia that is similar to iron deficiency anemia. Both of them lead to the same manifestations, and both of them give what? Hypochromic microcytic cells. And in contrast to iron deficiency anemia, beta thalassemia is characterized by slowed or defective synthesis of what? The beta globin chains of the hemoglobin molecule, and it is prevalent among people of Greek ancestry. Identify the clinical symptoms that are consistent with the diagnosis of iron deficiency anemia in this patient. This chronic blood loss, extreme weakness, tiredness, fatigue, craving for cold celery, and this is very unique for iron deficiency anemia. You get craving for some weird stuff you didn't have craving for before. Shortness of breath, progressive irritability, and difficulty concentrating. All these are manifestations. How about the signs? Tired looking patient, pale looking, rapid pulse, pale and cool skin, bluish sclera, slightly pale conjunctiva, systolic heart murmur because of the hyperdynamic status, low hemoglobin and low hematocrit, low red blood cell count, low MCV and low MCH, and low mean corpuscular hemoglobin concentration, and low serum iron, high total iron binding capacity, and low ferritin and low transferrin as well. Macrocytic anemia. What is most likely macro? Which one of these is most likely macrocytic? When can you get big red blood cell? When can you get big red blood cell? The best on the list is hypothyroidism. Do you mean that we can get high MCV and the cause is not anemia? Yes. So what are the causes of macrocytosis? Macrocytosis, bigger than normal red blood cells. Here are the causes. Of course, B12 and folate will lead to anemia. Alcohol can cause anemia, but hypothyroidism, liver disease, lipidemias, drug-induced macrocytosis are also common. All these conditions, you get MCV higher than 96 femtoliter. 72-year-old alcoholic man comes for confusion, weakness, fatigue, and pins and needles sensation in the hands and feet. He continued to drink while in nursing home. Hemoglobin 10, hematocrit 43, MCV 120. What do we have? We have a case of anemia, hemoglobin 10, and it is macrocytic anemia, MCV is high. Which one cannot be the diagnosis? Which one cannot be the diagnosis? Notice, pins and needles in hands and feet. What is this? Yes, peripheral neuritis. Now, folate deficiency anemia does not cause neurologic symptoms. How about alcoholism? Can it cause neurologic symptoms? Yes, it can. Alcohol can cause neurologic symptoms. How about B12 deficiency anemia? Yes, B12 is the only anemia that causes neurologic manifestations anywhere from peripheral neuritis up to dementia, and the most common cause of, or the most common presentation of neurologic manifestation of B12 deficiency is pins and needles in hands and feet, peripheral neuritis. Which test would you do next to diagnose the reason of this man's anemia? Well, let's talk about some of the tests. Methyl malonic acid level is the most specific test for B12 deficiency, and it goes up only in B12 deficiency anemia. Homocysteine level will go up both in B12 and in folate deficiency anemia. Chilling test, we don't do it anymore. It's just to diagnose pernicious anemia, which is one cause of B12 deficiency. And the anti-intrinsic factor and anti-parietal cell antibodies, again, these are tests for pernicious anemia, which is one cause of B12 deficiency. But by peripheral smear, I can differentiate. Whenever you see megaloblast, what's a megaloblast? It's a hypersegmented neutrophil. Megaloblast is found in B12 deficiency and in folate deficiency anemia, but not in alcohol-induced anemia. What's the most accurate test for B12 deficiency anemia? Of course, it's methyl malonic acid level. This is the most accurate test for B12 deficiency anemia, even more accurate than B12 level itself, which is cyanocobalamin, because again, cyanocobalamin is one of the acute phase reactants. It can be artificially boosted up by any inflammation. What's the treatment of pernicious anemia? Pernicious anemia, you have deficiency due to autoimmune gastritis. You have deficiency of intrinsic factor that is normally produced by the normal stomach mucosa, and this intrinsic factor is essential to absorb B12 in your intestines. So if you have lack of this intrinsic factor from your stomach, there is no point to treat it by oral B12 because it won't be absorbed. So you have to give parenteral B12 as a treatment for pernicious anemia. What could be an initial complication of therapy? Think of it. When you start giving B12 parenterally, the bone marrow is going to make a lot of red blood cells, a lot of red blood cells, a lot of red blood cells. What's the most abundant electrolyte inside our cells in general? It is potassium. So you expect to have hypokalemia at the initiation of therapy. A severely malnourished man has developed anemia with MCV of 109. That's macrocytic. Smear shows hypersegmented neutrophil nucleus. That's what? Megaloblastic. No neurologic symptoms. So this is not B12, this is folate. Which medication should be avoided? In folate deficiency, you do not want to give trimethoprim sulfamethoxazole, the Septrin or Bactrim or Septra. Why? Because sulfa antibiotics, they work by antagonizing folate. So you have a case of folate deficiency and you're going to give the patient folic acid. The patient is not going to make use of the folic acid if he concomitantly takes sulfa. Which drug decreases the absorption of B12? This is very interesting question. Metformin. Metformin, the most commonly used medication for diabetes on the long run. When you use it chronically, it leads to decreased absorption of B12 up to causing B12 deficiency anemia. Our case study about B12 deficiency is about a 26-year-old male who presents with pallor and fatigue. He complains of a 2-day history of difficulty expressing his thoughts and problems with both concentration and short-term memory. In addition, he describes a 3-month history of bilateral lower extremity numbness and weakness, peripheral neuritis, that has been progressing upwards, and gait difficulty. Identify 3 major risk factors that have likely contributed to vitamin B12 deficiency in this patient: excessive alcohol consumption, long history of poor nutrition, and chronic use of the gastric acid blocking drug famotidine for heartburn. All these are risk factors for B12 deficiency. What are some of the symptoms that are consistent with your diagnosis? Of course, the symptoms of anemia, but on top, you have to have neurologic manifestations: feeling terrible, unwell, old, and difficulty with concentration, difficulty with short-term memory, numbness in both legs, trouble walking, difficulty expressing his thoughts, numbness and intermittent tingling, all these, shooting pain, all these are neurologic manifestations very characteristic of what? B12 deficiency. And of course the fatigue and pallor and shortness of breath, all these are manifestations of anemia in general. So some of the signs of B12 deficiency anemia: the pallor, because it's anemia, and the skin mildly jaundiced, pallor of mucous membrane, and discomfort with flexion of the neck, systolic murmur, again in anemia, impaired mental status, and most important thing is the signs and symptoms of peripheral neuritis and neurologic involvement. Some lab blood test findings that are consistent with the diagnosis of B12 deficiency: low H&H, low platelet count, low white blood cell count, low reticulocytic count, and low reticulocytic proportion of red blood cells, low retics. This is low production anemia. High MCV, very characteristic of B12 deficiency anemia. High MCV, and of course your serum vitamin B12 concentration will be low. That this patient have pernicious anemia? Does this patient have pernicious anemia? The patient does not have pernicious anemia because tests for both serum antibodies for intrinsic factor and gastric parietal cells were negative. The case study of folic acid deficiency anemia is about an 80-year-old man. States that he has been feeling weak and terrible. What are the risk factors for folic acid deficiency in this case? Elderly patient, taking trimetrin, taking phenytoin, history of heavy alcohol use which continues, and patient also smokes. These are the risk factors for folate deficiency anemia. What's the significance of absence of parathesias and ataxias? So when you suspect, when you find macrocytic anemia with no neurologic manifestations, this is going to exclude vitamin B12 deficiency. What are the clinical manifestations of folic acid deficiency in this patient? The patient feels weak, no energy, and cranky, irritable, tachycardia is present, skin is cool, slightly pale, conjunctiva, systolic murmur, hyperdynamic circulation, low H&H, and low serum folate concentration, and anisocytosis, elevated RDW.